Let's go ahead and get started then, because we've got a lot to fit in this hour, and I want to make sure we have time to have a lot of discussion. So we're using a Prezi presentation instead of a PowerPoint this time, so hopefully there are no technical glitches, but if there are, just be patient with us, please. First, just welcome everybody. Thank you for joining us today. I know it's been a while since we met. Oh, there she is. Hi, Carrie. It's been a couple of months since we've all met together like this, because in October and November we were meeting with each team individually. So it's nice to have everybody back together. Today we kind of wanted to talk a little bit about what we've learned over the last few months. So first we're going to start with the team spotlight that we introduced in our last meeting, where we give a little credit back to a team that's doing a lot of good work. And then we're going to review kind of the current status of where all of our hospitals and collaborative are together through looking at the quantitative data that everyone's been submitting. And then we're going to discuss some of the trends that we saw as we did those interviews one-on-one with each hospital, some of the common trends we saw about challenges people were having and some ideas that were generated out of those challenges. And then lastly, we're going to talk about some next steps for our collaborative. So the second half of the meeting, we really are hoping to have a lot of discussion and feedback from you guys and what you've learned and what's been working for you and hasn't been working for you, and then also what you think would be most helpful as we move forward together. So I'm going to ask y'all to participate a lot, and I hope you all be on board for that. So first, let's start with our team spotlight. This month, we wanted to bring attention to HCA Tomball, who has done a tremendous job with a very overwhelming load. I think all of our hospitals have been very overwhelmed with maternal levels of care and Texas AIM and other initiatives going on in their hospital. But to add to that, HCA Tomball's delivery volume also tripled. So they had a massive staffing shortage in the middle of all of this. And everyone was staffing the floor while they were trying to get new nurses hired, and they stuck with it, and they continued to submit data every month, and continued to do small tests of change and work on their Muse policy. And even when HCA said we're gonna take it at a higher level and have our network come up with a plan, Tomball still said, well, we're gonna continue doing work in our own hospital to see how we can make it work here. So we just wanted to say that's tremendous effort there. HCA Tomball, we're very proud of Jamie and her team, and wanted to give you guys some credit and celebrate your successes. So congratulations to HCA Tomball. I'm going to hand it over to Dr. Epps to talk about our current status, and then we'll move on from there.
Okay. Amanda, I'm going to admit I didn't know you wanted me to talk about current status.
I'm sorry. I can do it if you want.
Go ahead.
Okay. So our current status, we started off in January with 15 teams, and 11 teams have been actively participating for the most part over the last year. We did have one DOA pending that actually got finalized late last week. So every hospital now has a DOA, and every hospital is now able to submit data, but that one hospital hasn't gone back and submitted for the last 5 months yet. So we are one hospital shy on our numbers in this set. On average, 9 hospitals submit some type of quantitative data monthly, and 6 hospitals submit some type of qualitative data monthly. But on average, only about 5 hospitals are submitting complete quantitative and qualitative data reports every month. And sometimes that's a little later, it comes in a little bit later, but they do go back and submit the full data report. The pie chart here shows where everybody is with implementation, and I think this is really helpful. We learned through the Texas AIM Collaborative that I think a lot of hospitals are realizing there are so many hospitals that are right there with them that they're not way farther behind than other hospitals. And so we really wanted to let you know where everybody in our collaborative here is, so that you don't feel like you're really far behind or struggling. So we do have, of our 15 hospitals, we do have 5 that have fully implemented a true Muse system. And that includes, there's the trigger criteria, there is a response at the bedside, and they do have escalation in their policy. 5 are currently working on tests of change, and there is a little bit of overlap there. We do have a couple hospitals who did go full wide with implementation, but are also in the process of testing that policy and seeing how it works. So there's a little bit of overlap in those 2 numbers. And then we have one team that is developing their policy right now, and it's awaiting approval. And then another team whose hospital network wanted to kind of create a policy for the whole network. So they're awaiting what that will be. And then we have 2 teams who have a Muse in place, but it doesn't include that response at the bedside component. So it doesn't meet the definition of Muse we're using for our collaborative here, but they do have criteria in place that they are using as early warning signals. So for our process measures, the first one is the education for OB providers and nurses, and you can see the trend upward. More nurses than providers have been educated, and we'll talk about that when we get to some of our lessons learned, but we're doing pretty well, especially on nurse education, almost getting to 100% there. The other process measure is the percent of patients that trigger Muse and then the fallouts. One hospital in July had a very kind of skewed that data up for that month. But you can see the overall trend here for those that are triggering and those that should have but didn't. Moving on to our structure measures, for those that have a policy in place, you can see the numbers here, and then also for those that are including the triggers in the handoff. We did want to let you know that structure measures, as well as the demographic data that we were asking for, that's part of the monthly report. Once you've entered it, it doesn't need to be entered every month. We don't, unfortunately, REDCap doesn't allow us a way to kind of deactivate the field once you've entered it, but I think Maliha is able to add a note, and Maliha, correct me if I'm wrong here, but you're able to add a note that if once that data has been entered, you don't have to keep submitting it every month.
You're correct,
Okay.
Amanda.
So for the structure measures and the demographic data, we know that's cumbersome to have to enter every month, and it's not really going to change month to month. So we did make that change in our meeting just a couple weeks ago. And so moving forward, if you've already entered this information or the demographic data, then you don't have to keep submitting that. The other structure measure, moving into outcome measures, here's our time from abnormal vital sign to provider at bedside, and then also for the return to non-trigger range. So again, one hospital skewed it up in August with a crazy high average response time compared to what they had been submitting prior to that and after that. And so we're working on reaching out to that hospital to make sure that data is correct, but that's why that 1 month is skewed high there. But for the most part, you can see a trend downward, sort of. And then for number of transfusions, excuse me, of at least 4 units, here's the trend that we've seen over the last 5 months. And then for ICU admissions. Does anybody have any questions about the quantitative data? Or about the data submission process? Any problems with REDCap that we need to address?
I was going to just add, importantly, guys, if there's anything that will streamline your reporting process, let us know. Like as an example, my hospital is one of the ones that had a hard time with the DUA, and it was only within the last, I'm not sure now, month or 6 weeks that we got ours in. So we went back to put in all of our data. And that was when we realized having to put in the same demographic stuff every month might be a bit of a barrier. So if there are other things like that, please let us know and we can figure out if we can make it easier.
Naomi, did you want to say something?
No, sorry.
Oh, okay.
No, we haven't had any issues in putting the data. I know sometimes I put it in a little late, but that's more of on our part.
That's kind of another thing we wanted to check with y'all about. I know one of our hospitals can't submit by the 15th of the month because they don't have their charts closed in time to do that. And so we were wondering if there are other challenges with the timeline, if we need to, we have it quickly because we want to give you a quick turnaround so you can use this information to guide your improvements. But we also don't want it to be burdensome and unrealistic and not possible for you to get it in that quickly. So if there are any challenges with the timeline, also please let us know about that.
Okay.
Okay, so then we got a lot of really good information from the one-on-one interviews that we did with every hospital. And so I really want to thank everyone for participating in those interviews and those meetings. We were able to pull the most common trends into these 4 categories. So related to implementing Muse and then educating on Muse, actually activating Muse and then tracking Muse. And so we're going to dive into each one of these and talk about some strategies that we've come up with and that we've heard from y'all about how to really facilitate implementation of Muse. So the first thing we saw a lot of people doing is going straight to the policy approval process and not testing it out first. And so we know a few hospitals that that are in our collaborative kind of have to have that policy before they can enforce it. But in general, we think the goal is that the policy is the end, not the beginning. And so creating some kind of guideline that you can implement first that's based on the goals of your unit. So educating about Muse and coming up with what goals you have for your unit, and then creating a guideline that has your triggers and your policy or your protocol, and then implementing that in a small area first in order to test it out. And then based on the feedback that you get during those small tests of change, revising that guideline until you finally have it pretty well settled into a final product that you can then turn into an actual policy. And then you re-educate about that final policy. And so we have a couple of hospitals that did it this way, and they thought that was really helpful because then they were able to implement right away instead of having to wait several months for the policy to get drafted, to get revised, to get approved, and then to finally get implemented. There was a lot of delay that could be involved there. And so hospitals that did it this way were able to implement right away and start seeing some improvement right away. Does anybody do policy first in the implementation versus implementing to define what the policy will be ultimately?
Well, I know we did the policy first and the protocol first, and I don't think it took us that long to get it approved. Our delays have been more after that.
Okay. Anybody else? All right. There we go. The next thing was related to multiple practices, and this kind of comes into building the policy as well. We heard that some challenges were getting multiple practices within the same delivering hospital to agree on a policy. And just this week in Lubbock, Dr. Morgan said something that I love. She said, "Don't let perfect be the enemy of good." And that ties in closely with something Dr. Epps has shared about the agreed upon way versus the perfect way. And so if we're spending a lot of time debating between different providers about what the perfect way is, we can lose a lot of time there. Instead, finding an agreed upon way is a great way just to standardize it, to reduce variability, and implementing an agreed upon way. And then from there, you can tailor it to try and see, well, was that the perfect way or do we need to change it? But at least at that point, you've reduced variability. Has anybody encountered having problems getting their different providers to agree? All right, the next one, and I think this is one that we heard from just about every single hospital we spoke with, is that there are a lot of competing initiatives, and it's a little overwhelming to have so many changes happening at once, and that there's, when Muse was implemented, there was a lot of enthusiasm toward it and it went really well, but then another initiative came up and the enthusiasm kind of moved to that initiative and Muse started to fall to the back burner. And so this is really where sustainability comes into play. Things that you can do to keep Muse sustainable is including it in your shift reports, which brings attention to it, twice daily. Even if you don't have any Muse events on a shift, even just saying we had no Muse events today on this shift still brings attention to it daily. Also including it in your simulations anytime you have a simulation, just making that one of the components of the simulation keeps attention on it. And then incorporating it into your weekly and monthly communications. And then lastly, continuing to track your Muse data to see if it is sustainable, or if you're starting to have more fallouts after you've implemented. Does anybody have any other ideas about how to deal with so many changes all at once? Is everybody tired today?
Everyone's tired from the trip.
Yeah.
No, I mean, I think that's been the hardest part for us here in UMC, has been with all the changes going on, not just for AIM and Muse, but all the changes in the hospital as well. It's been really hard the past few months to implement everything at once. And I guess at one point we were kind of waiting for things to calm down before we got going, and I think that was part of our fallout is trying to wait for things to calm down, because they never do.
Mm-hmm.
That's funny you say that. I feel like I realized that recently. Like, it seems like in a hospital, you're just moving from one really important thing to another really important thing. And I also realized things never calm down. One of the things that we tried is kind of having the pilot phase running parallel to an actual rollout of a different initiative and having different teams doing that. So usually in a hospital, the main QI team is the same people, and so it's the same people implementing. And as we did more work groups, we could actually have things going in parallel with one real rollout after we tested it and adapted it, and there's a go live date. And then we can be piloting little things on the side with a different group, trying it out. And that helped us a little bit be able to do a bit more, but I think everybody finds it a constant challenge.
Uh-huh. Yeah.
Naomi, did you come up with any strategies that helped overcome that?
What we're trying to do is, our main barrier, I guess, was like the staff knew about it and is essentially contacting the providers when they should, but they're not documenting it, or they're not using the correct terminology, or when they call the physicians. But what we're trying to do is give them more visual aids to remind them. So we ordered posters for every room with the protocol on it, and badge buddies and things like that. Just, we want to see if reminding them visually is gonna help change that a little bit. And then we need to be a little bit more specific on like exactly what we want them to document when they have a trigger and when they call the physician. We're having a lot of other documenting issues besides this part, so we need to address a lot of documentation.
I think that's where having more staff involved in the documentation auditing is really helpful, because then they see, oh, this is how I'm supposed to be auditing, and that's not how I've been doing it. And so it's educational as well as gets your auditing done. So
Right. Uh-huh.
And I'm glad you mentioned.
Uh-huh.
Oh, I was just gonna say, I'm glad you mentioned the visual aids. We're gonna touch on that in a bit, so I'm glad you brought that up. Anybody else have any other ideas here? All right, so the next one then is minimal resources. We have all these changes going on and only so many staff to help do them. And so Dr. Lundin really stress to just leverage who you have, and she did a really great job explaining this in the Lubbock learning session. But she said, instead of, you know, calling on the charge nurse to lead an initiative because they're the charge nurse, or picking your Texas A&M team and having these defined leader roles and have them do all of the work, really ask for people to self-identify as leaders. So if you have people who are particularly interested in Muse, even if they're not the charge nurse or not on the Muse team, like that's a great person to bring on the Muse team and help with that work, because that's what they're passionate about. And so they'll make sure that that work is moving forward. And then for other initiatives, you do the same thing. You ask for people who are interested in it, or you find people who are doing a really great job with it. So if you do have one nurse who never has a Muse fallout and she hits it every time, like that's a great person to go to and say, hey, you're doing a really great job with this. Would you want to be part of the team leading the effort? And so really leveraging who you have available on your floor and bringing more people into the work can help create more resources for you. And then, like I said, having more staff involved in the work gives the staff people a better understanding of the work that's being done, and then it also gives the QI leaders a better understanding of what's working and what's not from the perspective of everyone on the floor. So it doesn't have to be just a few people doing everything. You really can spread this out across your entire unit and involve everybody. Anybody have any other ideas of ways they've shared the work? All right. And then the last one under implementing is, we kind of talked about this a little bit, so many changes going on at once, where do you start? And again, this came out of one of the learning sessions. Somebody said, eat the elephant one bite at a time, and I just loved that. It can seem overwhelming if you're looking at the entire elephant, but it's still just one bite at a time. It's one change at a time, one test at a time. Just take it slow. It doesn't all have to be done yesterday. But also, I think everyone who's already attended the learning sessions this time, and I apologize for any hospitals in cohort 4 who haven't been to your learning session yet, but hopefully next week you'll agree. Hearing the patient's stories is extremely motivating, and tying their experiences into each particular change really gives context for why that particular change is needed. And so tying Muse into it with patient experiences, and then also linking Muse to all of the other components in the bundle, kind of shows why Muse is important and not separate from the bundle, but really part of the bundle. And so that can help with all of these changes that feel overwhelming. If you really give context for why they're happening, it's not going to make it less overwhelming, but it'll make people motivated to really make changes happen. And then really starting it small. Just go, like Dr. Epps was saying, just start with a small pilot in a small area while something else is going live unit-wide, instead of taking everything unit-wide as soon as it's ready to go. And like I mentioned before, creating different task forces for each change instead of using the same team for every single change. Or just some ways we've heard both from y'all through our interviews with you and from teams at the Texas A&M learning sessions. These are ideas that we've gotten for how to handle all these different components all in a relatively short amount of time. Has anybody had success with any of these ideas? Has anybody tried creating different task forces for different initiatives?
I was saying, I know that's the way TCH has rolled out the AIM bundle. Christina, do you want to say anything about that?
Yeah, that's exactly what we did with after the first learning session, where we kind of process mapped out what we had from the bundle and what we needed. We left there realizing that we kind of had four key areas that still needed to be implemented: QBL, risk assessment, making some modifications to our simulations, and then having a debrief right after a hemorrhage event. So we actually came back and we kind of hand selected ourselves, the groups, the nurse and a physician leader for each one of those groups, and gave them a few people to start out with, but then gave them the liberty to invite whomever else they wanted onto those teams, and set deadlines and kind of had expectations of what to do at each time point. And we got off deadlines, and they weren't always, perfectly met, and we rolled some things out later than we expected, or we had some barriers that we weren't anticipating. Some things ended up being easier than we thought they were going to be, and some things ended up being harder. And so we actually kind of accidentally rolled out almost everything all at the same time, and that's not how it was supposed to be. And so, but it has worked out. I think what we have learned from this will help us inform how we do things when we move on to hypertension and other bundles like that. I do think trying to create a little bit of spacing in between rolling out some really big things is a good idea. It just kind of didn't work out that way for us at the end, and everything just seemed to be ready at the same time. So we were like, okay, well, let's go with it now. But I think that also you do have to have I think another thing that we learned from it is probably whenever you set scheduled meetings, it's inevitable that something's going to get canceled because of, a holiday or just people not being available or something else coming up. So we realized we probably needed to have more frequent meetings on the book so that we met with the frequency, at least that which we wanted, rather than if you have something scheduled once a month and it gets canceled, you could go 2 months without meeting and talking about something. And so we had work group meetings that were scheduled, and also bringing all the work groups into one big meeting that was scheduled so that everybody was hearing what the other teams were doing and could kind of feed off of each other, because a lot of the work kind of played into what other people were working on as well. So I think it worked very well for us, but we also did learn a lot of things that we could do differently in the future.
Brandy, can I call on you to speak about how you did this in your hospital, or how you've handled multiple changes all at once in your hospital? Yeah. Are you there, Brandy? Uh-oh. She says she can't speak because she doesn't have her mic hooked up. All right, so I guess I can't call on you. All right. Moving on, there were a lot of things that came out about educating, especially providers on Muse. And so provider education, one thing we heard a lot was that the only arena for provider education was at service meetings that were poorly attended by providers. And so we started to brainstorm other ways to provide provider education, and we got some ideas from y'all. A lot of people were interested in using the webinars that we've created for Texas AIM, and then also the DSHS Grand Rounds presentation that Dr. Epps and Dr. Davidson did back in October. And all of those resources are excellent resources to use for education, and you can send them out to your providers and they can watch them on their own time. You can also create health stream modules where they have to go in and either electronically sign or take some type of little quiz or something saying, yes, I completed this education. You can create poster boards with Muse education and just post it in the common areas and nurses stations and break rooms or lounge areas. And then I know at least Dr. Epps has started linking certain education to her providers' privileges renewal. If they don't complete certain education, they can't renew their privileges. So that's a really big incentive for providers to actually complete the education that's been assigned to them. And then one hospital said they include Muse in all of their OB Grand Rounds, and that's been really helpful because then you're catching all the providers that are there as often as you do OB Grand Rounds. And so even if they're not attending the meetings, they're attending that when they're on the floor. So does anybody have any other ways that they've done provider education?
We had one of our providers presented at one of their, to the residents, to the residents and the faculty at one of their meetings. And they got about, I think it was like 40 or 50% of their providers in that one meeting. But I think maybe doing like a module or something like that would be easier to reach everyone.
Okay.
Amanda, one of the things oh, go ahead, Christina.
Go ahead, Carrie.
I was going to say, one of the things I've found challenging within education is there seems to be an inverse relationship between the number of people that you can reach and the degree to which they actually get quality information that they retain, meaning sending things out in emails or modules. You might reach a lot of people, but it's really hard to tell if they actually read it, understood it, synthesized it, and could do something with it, whereas those face-to-face things are really hard to get the numbers. You actually have some concept of whether somebody's gotten the knowledge, and it's just a really hard balance.
Yeah, and I think
that's exactly what I was going to say.
Brandy just shared through the chat that
And that's been obvious today.
that they just had a simulation today, and they had a drill on Muse triggers, and so all of the physicians came for the simulation, and then they had a drill on Muse, and so that helped with their education on Muse for their providers.
And that's an excellent way to make sure people retain it, as you have to like do the skills verification and simulation. So that's really smart.
Every time I open the chat box, the Prezi gets angry with me. All right, so then we have several hospitals who are more rural, either in a rural setting, or they don't have 24/7 in-house OB coverage, and they needed to incorporate the ED in their actual protocol. And so then they had challenges of how do we educate the ED? And so the first thing they did was they started including the ED providers in their simulations and debriefs. And then a great idea that came out was to collaborate with the ED educator on how to educate their staff, and then taking the education to them. So instead of inviting them up to the OB floor for education, they went down to the ED and brought the education to them with the Muse triggers, and also explaining how they differ from the early warning signals that are for the general population. I think those are all great ideas, especially, I think these are all great ideas for everybody, because eventually, we didn't tell you go start in the ED, but eventually you do need to take Muse to the ED, because a lot of our patients are readmits who are coming in through the ED. And so once you have Muse really established on your floor, you're going to have to take it to the other areas of the hospital. And so I think these are all great ideas for all of us. All right, the next kind of general category is related to activating Muse, and this is where Noemi was talking about just recognizing and activating Muse. Visual reminders have been helpful. We've heard this from several of our hospitals have ordered badge buddies. I know Brandy at her hospital blew them up and posted them on the computers, and other hospitals have posted them at nurses' stations and on their vitals machines. And so just having the algorithm or the triggers readily visible is helpful in recognizing. We also heard that a lot of hospitals were doing Muse, but they weren't formally activating Muse, and therefore they weren't documenting on Muse. So they would have a trigger, they would recognize that, they would call the physician, but they wouldn't necessarily say this is a Muse trigger. They would just call and say the blood pressure was this, or the heart rate was this, and the provider would come and assess, and then that was kind of the end. And it was after the fact that they realized, oh, that was a Muse event. And so creating that Muse terminology that standardizes the communication on the unit has been very helpful for some of our hospitals. And then Dr. Davidson brought up a good point in one of our meetings, that just because the provider is at the bedside, you still need to use that Muse terminology, because they might not be paying attention to the vitals. They might be in the room for some other reason, and as the nurse, you might assume, oh, well, the provider was there, they saw the vitals machine. And so a Muse event is happening with both people in the room, and it's not being communicated, and so it's not being activated. So those are some ideas that came out, just really focusing on Muse terminology and putting visual reminders everywhere. So for the Muse terminology, we actually.
If I can just give an example of that, because
Absolutely.
people could seem like, not paying attention to the vitals, but just truly focused on something else, like getting your attention completely diverted to something else. I recall a time where I was called to see a patient that I had done a scheduled C-section on, and she was still in recovery and she was bleeding from her incision. And I went to go see her, and I've never seen blood coming out of incision like this before, but I could tell that it was like a discrete bleeder, like under the skin. And I was trying to find out, like, was I able to hook up a Bovie and just, do it right there at the bedside, and just getting totally distracted with her bleeding, only to realize that after it was all said and done, she was sitting there having severe range blood pressures. And so I think that is a scenario where, just because I was there, I guess you could say I wasn't paying attention to her blood pressures. I was paying attention specifically to her bleeding, but I think that's an example of how you can just get so focused in one thing, and even though you're there, people need to make sure we are all talking the same language, so that it isn't just assumed that even though her vitals are right next to me, I'm actually looking at them.
Thank you for explaining that, Dr. Davidson. So through working with several different hospitals, we realized having some type of script would be very helpful. And so this is the script that was developed to activate a Muse trigger. And so the sentence in red there, "I'm calling to notify you of a Muse trigger," is the hard stop for everybody on the call, that this is Muse, that the expectation is the provider will be at the bedside in whatever time frame your hospital has established. And then you don't just end it there, you also you do a full SBAR, but then you close that communication with, "and I'll see you at the bedside within," again, however many minutes as your policy. And so we've sent this to several hospitals. I know one of the hospitals we sent it to, who's not on the call currently, found it very helpful. I'm wondering if anybody else has found having standardized Muse terminology helpful. And I know Brandy told me they haven't had a chance to try it yet because they hadn't had a Muse trigger since we sent it to them, but I'm wondering if they used it in their drill today. She said she's currently leading the drill with the night shift, but I believe her partner Jessica is listening. If she can, okay, hang on. Brandy said they handed the script to their physicians and they put it in the ER, but they haven't used it yet. All right, has anyone else used the standardized terminology or this Muse script? All right, if anybody wants this, let me know. It's also on our website, and I believe I added it to the Basecamp page. I'll make sure I did as soon as we're off this call, but I can also email it to you if I haven't already. All right, so then we also heard from some hospitals that having different types of Muse levels and different scores was a little confusing. And so having a single trigger system can really simplify the process and reduce confusion. And we also, through working with GE Healthcare, we learned that the OBUs in CPN can be customized, so you can it can still calculate a score, but you can also make it so that if any single trigger is there, it will automatically go to the whatever score you have designated as provider response. So you can customize OBUs in that way. And then we also realized there was maybe a little bit of confusion between just your normal notify house officer orders and Muse. And so I think really distinguishing between this is the level where you just have to call and notify the provider, and then this is the level where it's a Muse event and the provider has to come and evaluate the patient, and then only using that Muse terminology when you've hit that level can help reduce some of the confusion there. And then a couple of our hospitals were seeing a little bit of desensitization of blood pressure triggers, just because of the high number of hypertensive and preeclamptic patients they saw in their unit. And so again, this was a case where they were, you know, calling the provider, and the provider was coming to the bedside and assessing the patient, but because it happened so often, they weren't activating Muse every time. And so I think just going back to, you know, aims every patient every time saying is just something really important to keep in mind. But then you can also establish your expectations for when to re-trigger Muse for subsequent vital signs. And I know there are different ways of doing this, and I know the literature doesn't support any particular one way. I know Dr. Epps' hospital has a 4-hour time frame, whereas Dr. Davidson's hospital, it's a case by case, but it's established every time there's a Muse trigger, that part of the communication at that point is, okay, don't re-trigger Muse for this for X amount of time. So there are different ways you can do that, but I think establishing that expectation helps so that you don't feel like you have to activate Muse on every single blood pressure, even if it's been 10 minutes later, to help reduce with that desensitization. Anybody else have any thoughts on that? All right. And so we talked a little bit already about providers not being in-house and having to use the ED and the response algorithm. And an alternative to that is having standing order sets in place that you can activate while waiting for the provider to come. And I know we have at least one hospital who's used both. They have both incorporated the ED into their policy as well as implemented standing order sets. And when they call the provider with the Muse trigger, the provider specifies either activate the order set or call the ED physician to assess the patient. And then they're still on their way. They have, I think, a 60-minute response time, but they're usually there within 30, but at least that way something's happening while they're waiting. So we've created some order sets that, again, are on our website and have been handed out to the particular hospitals who asked for them. But if this is something that would be helpful for you, we can definitely send it out. But just having something like this available so that the provider can say, okay, do this while I'm on my way, has been very helpful for some of our hospitals that don't have in-house providers 24/7. And then the last topic is related to tracking Muse. And I think this is probably the biggest topic for, it seems like everyone that talks about Muse, the first thing they want to talk about is, okay, how do we get in the health records so we can track it? And so I think, I know we've talked about EHR integration in the past, and creating some type of flow sheet that is, has certain fields that you want to pull your reports on. Again, I think that you need to test it out before you build it into the EHR so you know exactly what kind of information you want to be able to pull from that flow sheet. But we also do have some hospitals who are doing it manually with the audit tools that we created. I think we have one hospital who's using the actual audit tool that we created, and then one hospital that kind of adapted it for what they wanted to use with it. But having something like this to go through and just helps you know exactly what information you need. Again, it's not, this is a manual process. It can be a little time consuming, but sharing that burden with lots of people, again, both helps with identifying the appropriate ways to document. It helps the whole team see the scope of the issue and understand the work that's being done. And it shares the burden of having to collect all of this data. So I do know a few hospitals are finding this helpful. Has anybody else come up with any great ideas for the data collection? Is anybody on the call doing it manually? All right. Well, that was pretty much the nuts and bolts of all of the information we pulled from, I need to go grab my computer cable real quick. Give me 2 seconds. Right back.
Okay, so maybe we'll just take a minute and see if there were other challenges or successes that people wanted to discuss. I think at this point, like we do for Texas A&M, Amanda was thinking about kind of voting what the next major topic we might want to talk about would be. I think that she has a kind of a list of the gaps that we might not have solutions to, and then we can decide what we want to spend our time thinking about. Amanda, jump back in whenever you have a cable.
I have a cable. I'm back.
Okay, perfect. All I said was that you had planned on kind of voting on what we wanted to spend our time discussing like we do for the breakout sessions.
Yeah, so if we go back to, sorry, if we go back. Here's the screen I want. We go back to here. Of those 4 topics there, is there one that people really want to spend more time talking about over others?
So meaning implementing Muse, educating on Muse, activating Muse, or tracking Muse. What do people feel like the biggest barrier is that we should spend our time focusing on? And folks can type it into chat if you would rather do that than unmute and talk.
Brandy, you said you would love to have this sent just as a comparison. What's that referring to? Oh, the order sets. Okay. Yeah, if you want to go ahead and send it in via chat. We really want to focus the discussion and the collaboration based on what everyone feels is the most helpful for them. And I see we've got some votes for implementation. We've got some votes for activating Muse. We've got 1 vote for tracking. Jamie, what questions do you have about implementation? What are you also not able, is your mic not able to be turned on? Okay. If you have a specific question, go ahead and send it through the chat box. Noemi, what would be most helpful for you?
Maybe just, I guess, hearing some of the other hospitals, like what they've done with their, like, different ways that they've done to fix their activation problems.
Okay.
Or maybe if any of them included, like, in team huddles or team steps, anything like that.
And then Jamie's asking about provider education and consistent nursing documentation. Consistent nursing documentation is something that came up in lots of different venues, actually. Does anyone have a great solution for how they've gotten nursing documentation standardized?
Or not even a great solution. It can even be things that you've tried that haven't worked that you wouldn't recommend other folks try, or things that you've tried and feel like you would do differently.
I think what has helped at my hospital is flow sheet documentation.
flow sheet documentation?
The providers generally document in a progress note, but the nurses document a lot in flow sheets. So just like oxytocin administration as well, that gets documented in flow sheets. So I find that when we put things into flow sheets, we have better documentation, and it's drop down menus of kind of the elements of what triggered the muse, who was notified, what time were they notified, what time were they at bedside. And so I think that has been one thing that I feel helped, because before we had that, we were going off of shift reports that were supposed to go from the bedside nurse, notified the charge nurse, who notified the house supervisor. And once we went to the flow sheet, we realized we were actually finding more from running reports out of our EMR on the flow sheet than we're actually making it onto the shift report.
Mm-hmm.
We're down to about 5 minutes, but this kind of leads into the plan for the rest of the meeting. We wanted to talk about next steps. And the first part of that is, originally we had planned to wrap up our reinforcement cohort at the end of this month, but we feel like everyone's starting to have a lot of momentum and really get some things implemented and are testing changes, and we didn't want to just jump ship right as that work is getting going. And so we wanted to propose that we extend our collaboration through the obstetric hemorrhage harvest in June. And as part of that, moving forward, what we would really like is to have you all continue with your Muse data metrics submission monthly, but then also to really plan the future meetings based on what you guys most want. So how we just voted on what you all want more information on, that's how we would move forward. What we see coming out of the qualitative reports that you're submitting, the PDSA cycles that you're testing there, the barriers that you've experienced and are overcoming, solutions and strategies that you've come up with. That's where this meeting came from, and that's where future meetings would be. And then also pulling together, kind of polling you all on what you want to focus on more. So it's really what's most helpful for you guys at this point. What would be the most helpful for you guys? First, do you like the idea of moving or continuing through June? And if so, what would you like the next 6 months to look like?
I like the idea of continuing through June, because I feel like we're kind of just getting to actually testing how we want to test.
Okay. And if you want to answer through the chat, you can. Got more people saying that June is good.
Is Muse going to continue to be like incorporated in the AIM bundle for hypertension? I'm assuming so.
Yes. Yes.
Okay.
Very much. In fact, it's absolutely critical for hypertension. So one of the, I think you guys will be ahead of the game. It's actually a listed item basically in a component of the hypertension bundle. So I think that all of the teams implementing the hypertension bundle will have to have at least the hypertension related components of Muse in place to do that bundle. And so we're thinking about how to make sure there are strong Muse components in the overall AIM implementation for hypertension as well. But it means you guys will be so far ahead.
Okay.
We're also, so the TCHMB annual summit is at the end of February. It's February 27th and 28th. And on the 26th of February, we're having a QI workshop. And we've heard through some different people that quality improvement concepts and tools are kind of abstract unless they're actually applied through an example. And so we want to do our QI workshops through the example of implementing Muse. And so all of the tools and concepts that we discuss, we will then apply to Muse implementation. And we were hoping that you all might want to participate on that as moderators for the workshop. So what we mean by that is we'll be inviting teams to come and work through Muse. There will be active working sessions just like at the Texas AIM Learning Sessions, and we were hoping that some of you all might want to come and help as teams are working through, just help moderate that. That's something that you'd be interested in, please let me know. I'll probably actually email you all about that. But that's what we're hoping. We're hoping that you guys will want to share the learning that we've all gathered here over the last year and move forward. So we're about out of time. Does anyone else have any questions or thoughts? Okay. I guess we can end then. Thank you, everybody.
Thank you.
Thank you.